Here. So welcome everyone to this month's Integrative Psychiatry presentation. And I am delighted to have my dear colleague and collaborator, Dr. Mari Ricker, joining us to present on the Integrative Medicine and Residency Education program. And I will just say a little bit about her. Her bio is actually very long, but this is the shortened version. Dr. Mari Ricker is professor in the Department of Family and Community Medicine at the University of Arizona College of Medicine, Tucson. She directs the Integrative Medicine and Residency program at the Andrew Weil Center for Integrative Medicine. And it is a delight to have her present and to learn from you, Mari.
Great. So the title of this presentation is really about sort of what's new with the IMR, and we have this new language. So I'll explain it a little bit more. So I'm sure you guys are familiar with IMR, even if you're not teaching with IMR, but it's the Integrative Medicine and Residency. So we all know about the definitions of integrative medicine and residency, but, we really embed these into our curriculum. And I sort of just put these at the beginning because I think it's always nice for us to just have a reminder of like what is most important for us in our training and educating learners. And I recently, I was inspired by, I think it was one of you all, it might've been, I can't remember if it was someone on this call, it might've been Sophia, but there had been a picture that you guys had used about like all the different parts of medicine that fit under integrative psychiatry. And I was inspired to kind of try and come up with a way of visually understanding and looking at all the different folks in the same space. And so this is sort of where I am now, and I appreciate any like feedback, but if I really think, and I'm obviously biased at integrative medicine, we are the sort of the bigger umbrella, and there's lots of complementary alternative medicine that falls into integrative, and some things that maybe have less evidence that fall outside. Functional medicine, lots of things that fall across and inside integrative medicine, then other things that are maybe have, from my perspective or our perspective, less evidence that fall outside. And then conventional medicine, a lot of it that does fall in, and then things that that fall out. And then I do believe that, everything involved in lifestyle medicine and all of their pillars are squarely inside of integrative medicine. So I think especially for learners who are trying to figure out all these different terms, I don't know if David, you can relate, like, learning about all these different things. I think I had a student ask me about precision medicine as well. So there's a lot of different sort of sexy new terms out there. And so sometimes it's helpful to have a visual as far as how these come together. Do you guys have any opinions or suggestions on that? I don't know what your thoughts are. I can see Amelia like thinking. I can see your mind.
Well, I was just gonna say, and I put it in the chat here, but what part of conventional medicine would you consider outside of integrative medicine?
I think for me, and I think I probably see a lot of things in family medicine that you guys don't maybe have to deal with, but I think there are a lot of things that are being done in conventional medicine that I don't think are evidence-based. I see patients going for procedures that are unneeded and don't have evidence. And, I had a patient recently who was taken to the cath lab and taken under risk where it falls out of the evidence. And, they can make quasi arguments that they needed to have this procedure, but I, as an integrative and family physician, I don't think that they were the best for the patient. So not everything, but I think some like more extreme interventions for me fall outside of integrative. So I don't know if there's any examples you can think of in psychiatry, but maybe like extreme polypharmacy.
So you're talking about the practice of conventional medicine versus
I think, yeah,
evidence-based conventional medicine.
Yeah. Because
Standard of care or like not standard of care, but maybe community practice.
Yeah, the longer I'm in, but they're in practice, and and considered mainstream, but, and like paid for by Medicare. But I mean, I think like trying to bring light to, the longer I'm in practice, the longer I learn that like people are practicing allopathic medicine outside of the evidence as well. And it's considered standard of care. So I think it really, I mean, we in integrative medicine, I think do our due diligence to make sure that everything we have a very high bar for our work to make sure that we, you know, can show that what we are doing has evidence, but I don't know that all of allopathic medicine is the same. So.
Thank you.
Are there other things in psychiatry I would love to hear that you think might fall outside?
I have a few examples, Mary.
Uh-huh.
In fact, Amelia had mentioned something that really made sense to me. She said sometimes, you just need a bicycle to treat something and people throw a truck at it.
Yeah.
And that's what I see with my residents. And it's, they think they're doing the right thing. Some of them think they're more biologically oriented than others, And I saw this clearly autistic, 22-year-old who, having not been diagnosed, has been going through mood episodes and chronic SI, but the symptoms have been there like lifelong, right? When you get the clear history, but then he comes to the hospital with these, SI or something like that, and the note stated how he's had multiple hospitalizations for these things and probably is a candidate for clozapine. And I saw that note and I was like, wow. And it was like, because I think because their mind and eyes are not trained to see neurodivergence, they see something and they want a quick fix. And when you speak out of conventional, that's what I see. Like, I just see people quickly, like if the body's going to stay under chronic stress, you're going to have endocrine issues, you're going to have the tight hips and the hip surgeries and the chronic pain and everything. So like everyone kind of moving towards that, but not wanting to acknowledge, where they're holding the stress or embodying their emotions. It's so much easier to go that route. So like constant investigations with neurology, sleep medicine, it's like I can't even keep up with 1 or 2 doctors. I don't know how people see 5 or 6, So I think the need to like have like a clear answer, objective answer, that it's not any of my trauma or my pain or emotions. I'd rather have it on paper. And I've seen several consultations for like people doing extensive functional medicine testing. But if you speak about something that happened in the past, it's like, don't touch it. And most of these women are like cops, absorb stuff and are like, nope, don't go there. But now these are the physical manifestations I'm having, like, let's have answers for those. Let's just keep going to Mayo and doing stuff. So that's sort of what I see with conventional.
Yeah, I mean, I think there are a lot of things that we do that are harmful. Like I think of in family medicine and, putting tons of people on PPIs, like having everyone on proton pump inhibitors for no reason. We have so many reasons not to do that, but people do it all the time. It can cause osteoporosis, aspiration, pneumonia, lots of downsides, malabsorption. Like that doesn't fit in integrative medicine. And like there are so like in the, just throwing everyone on a PPI for mild stomach ache, and other, lots of other harmful things that we do. And I think, in the ER, I was talking to someone who also is sort of integrative minded. And he was saying he sees his residents just like scanning people from head to toe, just because without taking the time to listen and do a really thorough history and really, prevent that harm from finding some incidentalloma that then we go tracking forever and ever. So. Anyhow, thank you for looking at my picture. I keep moving it a little bit and maybe the balls need to be moved, but I think it's really helpful. I don't know if David, especially early on, like learning about all these different terms, like how you wrap your mind around them. So I had a med student who I was talking with recently, and she actually mentioned precision medicine. And so I need to think about where to add that because I think it's probably more like functional medicine. There's some things that I laugh at the term precision medicine because it's like so technical and like it includes all this genetics and things like that. But I feel like it could be so high touch and just be precisely in front of the patient with you and be very precise without having to be high tech. So I don't know. All these terms are really interesting. Okay. So just a little history of IMR. I mentioned that I've been here for about 10 years, so about halfway through this timeline, but it started many years before. In 2006, actually, Patricia Levinson and Victoria Mazies, with the support of Dr. Weil and the Weil Foundation, had this idea. They started with a handful, just 8 pilot programs. The needs assessment, the faculty said, we just want 25 hours of curriculum. That's all we need. It turned out it ended up being 200 hours. And so you don't need to follow all of these different numbers, but by 2010, we had about 30 sites, 50 sites when I started in 2014. Now we're up to 120 sites in 6 different specialties. We've added OB, internal medicine, pediatrics, psychiatry, as you know, preventive medicine, PM&R, and we're doing a pilot with emergency medicine. So we're really trying to just expand. This is just a little bit more of the evolution. I don't need to go into the details, but one of the important things is, when we started in 2008, it was 200 hours. When the psychiatry started, we made like a very unique program for psychiatry and took a lot of the, general medicine things out. There's but we found there's a lot of overlap. Well, there's important gut things that psychiatrists need to learn in the, other areas, neurology, things like that. So, this year, I've been really motivated to get the program to be smaller, because we have just seen that the residents have a really hard time bringing in 200 extra hours during their training. And we want to be mindful of resident, professional fulfillment and well-being, and not add to that distress. And so I've been working with each of you, your leaders and the different programs. And we interviewed site leaders, program directors, the leaders in each specialty, to find out which are the really most essential aspects of integrative medicine that all residents should learn. It was challenging to find, we had to add a lot of pediatrics back in. We had to add more of the psychiatry back in, just to really make sure that this core program was relevant for all specialties. And so what we've done is gone from 200 hours or 100, I think we were at 125 for psychiatry, and now we have 85 hours of core curriculum. And it's the same thing. They do 80% completion and 70% on the final to receive a certificate. And then we have created an additional 85 hours organized really by subspecialty or deeper dive in whole system. So that residents, like psychiatry residents, want to take a deeper dive in neurology, advanced psychiatry, or maybe they have deeper interest in Ayurveda or other, whole systems, but they can really customize their additional advanced work. So these are the units that we decided to keep in the core, and this was with a lot of different feedback. All of the lifestyle interventions, supplements. So lifestyle also includes like minerals and other nutrients, vitamins, foundations in mind, body, some systems and approaches, which includes like the whole systems and manual medicine, things like that. And then clinical application, which includes psychiatry, a little bit of women's health, and a little bit of diabetes. But it was interesting when we interviewed all of the really generalist specialties like family medicine and internal medicine, all of the site leaders and program directors said, we need core training in anxiety and depression. We need that to be in core because our residents need it for themselves. So I thought that was a really interesting driver. So these are like just the major changes that we are having in July. Instead of having 6 different programs, we're having one program that all specialties are able to enroll in. And so in a couple of locations, this has been really exciting. Like UCSD, for example, they have pediatrics, family medicine, and preventive medicine are all enrolling in the same program. So it's not limited to a certain specialty. We have no minimum resident number. We used to have, you have to have 4 or 5. And we have a flat rate for each resident, and they can access during the residency until they graduate, and then for that additional year. And really, with this opening it up to any specialty, I'm hopeful that this just really enhances our ability to connect and share with other residents. We have one other feature that's new, and this is kind of a fun activities module. We have so many new sites, and some of them are really experienced and really have a lot of individual training, like you all have, like with the Center for Mind-Body Medicine and other things, but some site leaders are feeling like they needed some support. So we created some activities that each of the residents could do on their own, or that they could do in community with a group of other learners at their program. And so we created activities for each of these different areas, and they are all designed so they could be done as a solo activity or in a group. And that is it.